Hello, and a very warm welcome to all of you. Thank you for joining us and supporting DocPlexus in our journey of 9 glorious years celebration last month. Welcome to the DocPlexus Global Diabetes Summit 2022, which is a 3-day clinical discourse organized from 12th to 14th of November to discuss and tackle the largest and most affecting disease of the world, discussing topics around access to global diabetes care and education. You all must be aware that 463 million adults, that is 1 in 11, were living with diabetes in 2019. The number of people living with diabetes is expected to rise to 578 million by 2030. 1 in 2 adults with diabetes remain undiagnosed, which is about 232 million. The majority have type 2 diabetes. Talking about the prevalence of diabetes in India, currently India has 77 million people affected with diabetes, which makes it second most affected country in the world after China. The International Diabetes Federation has projected the number to grow to 134 million by 2045. Out of this 77 million diabetic patients, 68% are being treated with oral hypoglycemic agents, 25% are being dependent on insulin, 7% are being treated with injectable GLP-1. Amongst children, according to a study published in the Indian Journal of Endocrinology and Metabolism, it is estimated that India is home to about 97,700 children with type 1 diabetes mellitus. So we can make an assumption about the plethora of issues that the world is facing currently due to diabetes. In response to this, DocPlexus brings to you the Global Diabetes Summit, which is spread across 3 days. For day 1, we would be addressing the diabetes linked to cancer and surgeries for diabetes treatment. For day 2, we would be presenting to you on a 1-credit ACME webinar on A to Z diabetes prevention, management, and advances. Please note that registration for ACME sessions are still open. Day 3 would be an expert roundtable discussion with renowned international and national panelists on the latest development in management of diabetes, along with another panel for addressing the holistic management of diabetes. Now coming to today's session, surgery for diabetes treatment. Over the last decade, bariatric surgery has been shown to be an effective treatment for type 2 diabetes mellitus patients. Surgery is associated with superior improvement in hyperglycemia as compared to best medical treatment, an effect that is sustained for at least 5 years. The improvement in hyperglycemia is associated with a reduction in mortality and diabetes-related complications. Improvement in type 2 diabetes mellitus following bariatric surgery is mediated by both weight loss dependent and weight loss independent mechanisms. To tell us more about this, we have with us bariatric surgeon Dr. Goel. Dr. Goel is the first master bariatric surgeon from Asia accredited with the Bariatric and Metabolic Surgeon of Excellence by Surgical Review Corporation, USA. He is known for performing India's first first banded gastric bypass, and first mini laparoscopic bariatric surgeries, and many more. He is currently the Director of Bariatric Surgery at Wockhardt Hospitals, Mumbai. So without further ado, let's begin with the session 2 of day 1 of our rich science-driven discourse.
Good evening, friends. On the eve of World Diabetes Day, I am glad that DocPlexus has taken the lead to conduct this series of webinars, and I thank the DocPlexus team for inviting me for one of them. So today we will be talking about diabetes and how this can be managed surgically. And I'll be very happy to answer your questions if there are any through DocPlexus platform in future as well. So thank you so much. I am Dr. Goel, I am a metabolic and bariatric surgeon at Wockhardt Hospital, Mumbai, and I'm doing these surgeries for over 20 years now. And I believe that diabetes requires more than medicines for a certain number of patients, because diabetes remains uncontrolled in over 70% of patients, and these patients end up with complications of diabetes. And they if a surgery can be offered at the right time, then they can avoid these complications and they can avoid the morbidity of those complications, and they can live longer. So friends, I'm going to show you a video of a gastric bypass. Now this is a edited video, because obviously gastric bypass takes around an hour to do, and I'm going to show you some steps that adds to the safety of the surgery. Don't get carried away by the amount of work that is required when we do this surgery. What you need to understand is that this surgery can be safely done. It's a very measured surgery, and the outcomes are also predictable. So I'll share my screen and I'll show you a video. So this surgery requires 5 ports, and it's a laparoscopic surgery always. So at the moment we are putting ports in upper abdomen, and we can do with 5 ports. And right at the beginning, we look at the health of the bowel. So what we are trying to look is that whether patients have a Cox abdomen or a Crohn's disease. And once we are sure, we go to make a pouch of the stomach. That means we make a small stomach pouch. And here what I am doing is I am exposing the angle of his. This is the left crus, as you can see. This is the left crus here, and I am exposing it, and this is the stomach, and there is the spleen. So this is the, and once that is done, we go along the lesser curvature of the stomach. Now this is the lesser curvature of the stomach. We go about 4 to 5 centimeters from the OG junction or esophagogastric junction, and we are trying to go behind the stomach from the left side, from the right side, sorry. All right. So this is the stomach. This is the lesser omentum, and we are making a small plane here. It's about a 14 minutes video, so have patience, because you need to see how it's actually done. Because patients ask physicians as well how this surgery is done, and if you have an idea about this, it will help you explain them. So what I'm trying to do is to lift the posterior wall of the stomach away from the fibrofatty tissue between this and the pancreas with my 2 instruments. And it's a very narrow space. It's just a 1 centimeter space. And see, I have opened the lesser sac there from the right side. And once that is done, I put the stapler horizontally, all right, on the gastric wall. So this is the anterior gastric wall, and we are making a very small pouch. This whole thing is a stomach over here. So we have divided it partially. A very small pouch is just about 4 centimeter. And these are the adhesions between the stomach, posterior adhesions of stomach with pancreas. We are dissecting them so that we can make a vertical firing. So I'm going to the same angle of his from behind. And once that is done, I put the stapler vertically, and the anesthetist passes a calibration tube so that I can make a small pouch. And see how small is this pouch. This is a 6 centimeter stapler, and this is going across. So this is a 30 to 50 cc gastric pouch that we are creating. And so this will be the, and little bit is left, so we are firing another cartridge here. And once this is done, The two parts of the stomach now, the one that we have created and the remnant stomach, are completely separated. And once this is done, on the calibration tube, I am making a small hole or a gastrostomy so that I can do a gastrogenostomy later. So you see that blue thing, that is the calibration tube. Once this is done, then we go and divide the omentum. Now we do it routinely in every patient, irrespective of the thickness of the omentum, because we believe that when patient stands, the omentum can put weight. Now this is the DJ or duodenojejunal junction. This is the jejunum, and we are measuring the jejunum from the DJ. Now in our practice, we are very careful that we should not cause malabsorption in a Roux-en-Y gastric bypass. So we measure it mostly 50 centimeters from the duodenojejunal junction, and then my assistant is holding it on the BP limb side while I am holding it distally, and I am making a small opening in the jejunum. So enterotomy is being created for the gastrojejunal anastomosis. So this is done, and a stapler is put in the jejunum, and it is also passed in that small opening that we have created on the stomach. All right. So I hope you are able to follow this. And this is, we calibrate it to under 3 centimeters here. And we are doing a gastrogenostomy away from the vertical staple line on the back side. Now, all these are very precise. They have to be done precisely because bariatric surgery is just like oncological surgery. Either you do it perfectly or the results will not be good. And that is why just completing a surgery is not enough. You have to do it properly, right size of the pouch, right size length of the intestine. If you take longer intestine, you will have malabsorption and patient will have problems in long run. Now, here we are doing a closure of this enterotomy, suture closure, and we want to make sure that there is no leak. In gastric bypass, generally leaks don't happen, and that is because these enterotomies are properly sutured and closed. So you can use a barbed suture or a non-barbed suture, depends on your preference. I generally use non-barbed suture, but this is more for demonstration purpose because many surgeons would prefer to use barbed suture because of the simplicity of suturing. And so you start from one angle and you make sure that both the corners are taken. So once this is done, you can go ahead step by step. Make sure you don't move very far from each other, each bite. And a good technique is to avoid taking bites in this strip of the stomach. Go across the stomach so that this portion, which is so close to a staple line, should not get devascularized later. And we have gone all across. And once we have done that, we do a second layer. Always we are doing a second layer. First layer was with the absorbable suture with PDS, and the second layer is with the Prolene, a non-absorbable suture. Many surgeons do it in single layer, and I don't hold them as accountable for this because that's a standard technique. Once that is done, then on the BP limb side, we make a small window where we will divide this to convert it into a Roux limb. So we create this window right now and leave it because this will be used as the last step of the surgery. And then on the same side, on the BP limb side, we make a small opening in the jejunum. Again, we leave it, and then we start measuring the Roux limb. We always use umbilical tape to measure, and our Roux limb is standard 100 centimeters. So our BP limb is 50 centimeter and Roux limb is 100 centimeter. I can discuss the reason for being conservative in these limbs because most of the people would like to do a longer BP limb, but they patients will end up with deficiencies. They are likely to end up with deficiencies in long run, and we do not want that. These patients are our patients, and we will make sure that they should not end up with deficiencies. Once we have measured 100 centimeter, my first assistant is holding it here, and I'm holding on the right side, and then make a opening into the jejunum. And then we put a white cartridge, because now we are working on the intestine and no more on the stomach. And we take it to the opening that we had done in the BP limb. Up there, the tape has been taken out. This opening that we have created earlier, all right, to create a jejunostomy. Now this is a 6 centimeter jejunostomy. One can make a 4.5 centimeter jejunostomy, but not longer than that, to avoid intussusception in long run. And the stapler is put in both the arms, the jejunum, all right, which are matched to make it a small opening. Yeah. And the stapler is fired. We generally use power staplers because we find them more, they give more uniform stapling. And then this enterotomy is closed again in 2 layers. As you can see, I am trying to do it extramucosal, the first layer. If you do it extramucosal, actually second layer is not required, but we have been doing it right from beginning, so I don't want to change my technique. And once the first layer is done, the same PDS, running PDS, which is 30 centimeter long, is used as a seromuscular layer. So I go all the way up where I had put a stitch initially, and then I come back on the same thing. And once this is done in 2 layers, we divide the jejunum, so it will convert. Now we are doing a mesenteric defect closure. This is done now routinely by us with a barbed non-absorbable suture. So we are showing you Stratafix being used, which is for some reason undyed material, but we start right at the bottom of the defect, and then we go up. It's necessary that whenever you are closing mesenteric defect, you do a very good job, because if you leave small defects, then there is a problem. So we do continuous sutures, barbed sutures, and all the way up. And since it's transparent, it's a little difficult, because they are right, they merge with the background of the mesentery. But as you can see, because they're barbed, it's easier to hold. They are hemostatic, and we go all the way up till we reach the bowel, and we close the defect even between the 2 bowel ends, so that later on the internal hernia should not happen. Internal hernia is a Achilles heel for Roux-en-Y gastric bypass, and every surgeon who is doing gastric bypass should do a very good job of closure of mesenteric defects. So that is one. And now I'm closing the Peterson's space. So the Peterson's space is between the roux limb, the mesentery of the roux limb, and the transverse mesocolon. So what I am holding is the retroperitoneum now, and then I'll take the transverse mesocolon, and we tie it from behind. So this is the retroperitoneum. The first bite was in the mesentery of the small bowel. I'm just pointing out a vessel there to my assistant, and then this is the transverse mesocolon. And one can do it 2 ways. One can do like collecting sutures, which I generally don't do nowadays, or one can do a running suture, as I've shown you the mesenteric defect earlier on the other side. So this collecting suture, generally nowadays I don't do it, but serves well. If you are not very sure of continuous suturing, one can do this, um, like a persisting suture. So takes the mesentery, 2 bites on mesentery of the ascending this thing, the rule limb, and 2 or 3 bites on the transverse mesocolon, and then they are tied together so that the whole thing collects and obliterates the defect. But I think Peterson's defect closure is absolutely essential, whether it's a Roux-en-Y bypass or one anastomosis gastric bypass. We do it in every patient, and we have never repented, though it may take a little, say, 5 to 10 minutes extra time at the end of the surgery. But uh, we don't see the defects or internal hernias later in our patients. Once this is done, then we do a air fluid leak test where we infiltrate abdomen with the saline, and the anesthetist is injecting air through the calibration tube. And since it's a very small pouch and a stroma, about 100 cc air is what is maximum required to be pushed in. And if there are no air bubbles seen, then we know that there's no leak here. The difference between an air fluid leak test and a methylene blue leak test is that in air fluid leak test, we are not putting any gauze piece around. Even if there is a smallest leak, the bubbles will float. So what I do is I do air fluid leak test in every patient, whether sleeve or a bypass. And if I find a leak, I will go in and if you cannot find a site of leak, then and only then I will do a methylene blue leak test with a gauze piece, because that will lead me to where the leak is happening. If you do air methylene blue leak test routinely and without putting gauze piece properly, it's possible that the entire area becomes blue, and then it's very difficult to find the site of leak. So I touch wood, we never had a leak in gastric bypass. We have never seen a leak on gastric bypass, but in sleeve gastrectomies, we have seen leaks on table and afterwards. And I've realized that air fluid leak test is a better option. So I think uh, people who are worried about Roux-en-Y gastric bypass and its technical requirements must understand that if you know suturing well, Roux-en-Y gastric bypass is not very challenging. You need to see, assist, or do some cases under a mentor, and you can do it because it's just a repetition of stapling, suturing, and you need to do that for let's say about 1 hour. But in long run, it remains probably the gold standard of bariatric surgery to give the best possible results in terms of weight loss, in terms of diabetes remission, and without major nutritional issues that we see in malabsorptive procedures. So as physicians and doctors keep saying, do no harm, that's a first requirement. I think that is more important in bariatric surgery, because we are trying to reroute the whole thing, intestine or the food. If we create malabsorption by any surgery, it's not a question of only MGB or one anastomosis gastric bypass. By any surgery, we are leading patient to a situation where they will lifelong are under malabsorption, and if they are not going to take supplement, they can have problems. So I think technically both the surgeries are similar. Gastric bypass remains gold standard for a reason, that it is probably the healthiest bariatric surgery that we have encountered in last 60 years. And that is why over 100 types of bariatric procedures have come and gone, but Roux-en-Y gastric bypass has outlasted all of them for last 60 years. And for diabetes, it has both. It has a duodenal exclusion and also hindgut, because the food reaches faster in the ileum and causes GLP-1 release. But if there are any questions, please feel free to send them to Doc Plexus and I will reach out to you to answer them.
It was absolutely wonderful listening to you. Very well presented session. Lot of takeaways for the audience. We have a few questions from the audience. With your permission, let's go on to the first question. How should a patient maintain his remission after undergoing a bariatric surgery?
So remission of diabetes after bariatric surgery means that the person doesn't require medicines for control of blood sugar. Now, this is a very important development because, we always knew that diabetes is a lifestyle disease and diabetes is a lifetime disease. Once somebody starts taking medicines, those medicines go on lifelong. But after bariatric surgery, the patient is able to stop taking medicines within a week or within 10 days. Now, how does he maintain this remission long term? It's very simple. All that the person has to do is to avoid things which are advised for a diabetic patients. So avoid taking sugars and sweets every day, avoid having white flour, white rice, those kind of things which have a high glycemic index. Now, this is a concept which most of the patients are not aware of. Glycemic index means if you eat food which release blood sugar rapidly. So all that you have to do is to go on the Google and say glycemic index of Indian patients, glycemic index of Indian diet, I'm sorry. Now you will get a list of food items which may include chapati, which may include rice, which may include dal, which may include chicken makhani, whatever. And you can see that those food items which have a glycemic index below 55, you are allowed to have as much as you want to eat. Those between 55 to 70, you can have them in limited quantities, and above 70, you should not have. If you just take this precaution, you will never go out of remission. That means you will remain controlled diabetic lifelong without medicine. And on top of it, if you are exercising on a regular basis, a muscle consumes blood sugar rapidly. If you are exercising on a regular basis, your remission will be maintained lifelong. So I think just two secrets to maintain remission after bariatric surgery. And as such, remission is maintained in almost 25-30% patients after surgery. So I think if patients are a little more careful about their food choices and regular exercises, they will not require medicines long term after surgery.
Thank you for that answer. Moving on to the next question. What are the medications that needs to be continued or started after one undergoes surgery? Does the patient have to change his diabetic medications?
I think that's a very important question because most of the patients ask this, and even the family physicians want to know. So there are two things: diabetes medicines or any other medicines which are required after bariatric surgery. Generally, those who are on insulin before surgery, insulin stops within 2-3 days or maximum within a week after surgery. So they will not need to take insulin again. As far as tablets of diabetes are concerned, in most of the patients, they stop within a month after surgery. So diabetes medicines are not required in most of the patients after bariatric surgery because they go in remission. And so this is a very big relief because most of these medicines themselves have some side effects and they can be avoided now. Now, as far as do they need to take any other medicines? No, not really. They need to take some food supplements because they are eating a very small meal. So they need to take some protein shakes, 1 or 2 multivitamins, maybe a calcium tablet or an iron tablet. But these are required by most of the diabetes patients or patients with blood pressure in any case. So I think there is no compulsion of taking medicines after bariatric surgery except few supplements, and those supplements are for your health. And thus, if you are taking 12 medicines before surgery, after surgery, only supplements will be left, and most of the medicines can be stopped.
Thank you for that answer. My next question to you is type 2 diabetes mellitus requiring insulin is considered too advanced to be reversed by bariatric surgery. What is your observation on this?
I think there is a misconception about insulin intake. Well-informed patients, or let's say the doctors who themselves get diabetes, like to start insulin very early. Why they start insulin early, even if it is not required? Because that way they protect their pancreas from getting damaged. So if you start taking insulin early, your pancreas can last for a long time. And thus we get many patients, especially in city of Mumbai, who come to us and they say, our doctor gave us an option that you start insulin or you can take tablets, and we took the option of starting insulin early. So that is one set of patients who chose to start insulin early and their pancreas are in good shape. So they cannot be called advanced diabetic. They are diabetics whose pancreas are well preserved. And even otherwise, patients who have started insulin, let's say 3, 4, 5 years after they got diabetes, they if their pancreas are functioning well, and there are specific blood tests by which we can find out, like C-peptide, fasting C-peptide. If it is more than 1, that means pancreas is functioning, and if it's more than 3, then pancreas is functioning very well. So I think patients who are having a fasting C-peptide of more than 1 or more than 3, we can definitely offer surgery and they do very well. So this is something that a physician can easily get checked on their patient and decide whether the surgery will be effective for them.
Thank you for that insightful answer. My next question to you is how can bariatric surgery help patients with type 1 diabetes?
Now, type 1 diabetes is a controversial area because primarily the pancreas is the one which is primarily affected. The pancreatic damage has already happened because of antibodies, and they are short of insulin production right from the beginning. So theoretically, we do not advise a surgery in type 1 diabetes for diabetes improvement. Now, most of the type 1 diabetic patients are thin, so they assess they don't need this surgery for weight loss. But we are increasingly seeing patients now who are obese or morbidly obese, and they can be offered this surgery for their weight loss. Now, in the process, their insulin requirement goes down. So if they were taking, let's say, 100 units a day or whatever, now that requirement will go down because the overall the weight loss happens. So if they were requiring 100 units, now they may need 60 units, or they may have better control with 60 units. So I think uh, the indications, the reason for doing a bariatric surgery is different in type 2 diabetes and type 1 diabetes. In type 2 diabetes, we are offering it to achieve remission, while in type 1 diabetes, we are offering it for weight loss and better control with insulin. I mean, these people do not go off insulin. They will still require insulin, but the requirement goes down.
Thank you for that answer. Moving on to the next question. How should a surgeon decide on which surgery, that is, Roux-en-Y gastric bypass, sleeve gastrectomy, or gastric banding, to perform on a patient?
I think it should be left to the surgeon, but uh, in simple terms, uh, patients who are, uh, let's say, let's talk only of weight loss. So patients who are coming for weight loss and they do not have any other disease, weight loss is almost similar, maybe 5-7% difference between sleeve and bypass. So I do not select between the two. I say if you do not have acidity or reflux, I can offer a sleeve gastrectomy. If they have acidity or reflux, I offer them a gastric bypass. Now, if they have diabetes, and if diabetes is less than 10-year duration, or if they are taking insulin for less than 4 years, we can offer them sleeve. Of course, they can also go for bypass. It's their choice, ultimately, patient choice. But if they have a diabetes for more than 10 years, or if they are on insulin for more than 4 years, I generally prefer a bypass. So these are broad criterias. But ultimately, patients have seen other people who had surgery, they have their own preferences, and they decide. But in my own practice, now about 70% are gastric bypasses and about 15 to 20% are sleeve. And the reason why this is there because almost 60 to 70% of patients with obesity do have reflux disease. And I do not want to offer them a sleeve gastrectomy anymore. So simply saying patients with reflux disease referred to surgery is a bypass. Patients without reflux disease, one can choose between sleeve and bypass.
Thank you for the detailed answer. My next question to you is, are there patients whose diabetes were not affected with bariatric surgery? Could you point out what goes wrong in such patients?
Okay, that's a tough question. Now, generally, always patients benefit from bariatric surgery. Okay, there are very few patients who will not benefit. Almost 100% patients will have a better control. Now, patients who are having diabetes for a long time, let's say somebody has diabetes for 25 years, is on insulin for 10 years, that person may not go off diabetes medicine completely. They may still require medicines. Okay. But what will happen is that they may stop taking insulin and they may still require one or two oral tablets to control their blood sugar. So one can relatively say that you were talking of remission, but remission did not happen. But the question is not remission, question is not whether they can stop medicines. Main question is the quality of life and control of diabetes. Now, these patients, HbA1c will remain below 7, maybe with one tablet or two tablets. While before surgery, the HbA1c was 9 or 11 or 13 or 15. I mean, we see all types of patients coming to us. So even with medicines, with insulin, the person's HbA1c was 15. And now after bariatric surgery with just two tablets, it comes down below 7 and they don't need insulin anymore. So I think it's all a relative question. Patients' quality of life becomes excellent because they don't need to check their blood sugar 3 times a day before every meal and before deciding how much insulin they should take and then poke themselves with insulin. So patients are very happy. But your question is not an easy one to answer because there will be patients who are long-term diabetics where pancreatic function is not very good. And a simple answer to physicians for this question is, please get their fasting C-peptide done. If it is more than 3, they are excellent patients for bariatric surgery. If it is between 1 and 3, then they are in this range that they may still require medicine, but they will improve. If they are below 1 C-peptide, then it is one must be careful because these patients are probably going into a type 1 type of diabetes and they may not improve. So even before surgery, you can prognosticate or you can tell the patient how their outcome will be after surgery. They don't need to undergo surgery if they don't want to. Yeah.
Thank you for that answer. Moving on to the next question. Is there a higher, lower, or lower age restriction for patients to undergo bariatric surgery for diabetes?
Yeah, I mean, there are guidelines which says that, you should not do it below 18 years and now you should not do it above 70 years. But guidelines are guidelines. There are young teenagers who are like 13, 14 years and they are suffering from uncontrolled type 2 diabetes. Should I wait for 5 years and by the time their pancreas will get damaged enough that they will not benefit from surgery? So we do offer these surgeries in teenagers, let's say in girls below 13, above 13 years and boys above 15 years, because we wait for their growth or bone growth to happen before we offer them this surgery. So generally 13 years and above for girls and 15 years and above in boys, we do offer this. And above 70 years, if they are medically fit or to undergo anesthesia, I still perform these surgeries, because I believe uh, even in old age, quality of life is very important, and there is no reason to deny them the benefit of this surgery. So it has to be on a case-to-case basis, but in general, guidelines say between 18 to 70 years. Yes.
Thank you for that answer. Moving on to the next question. How can bariatric surgery reduce the overall cost burden on the healthcare system?
This is humongous. This is the cost of diabetes is humongous. A patient who is on medicines for diabetes for many years knows that the cost of medicines could be as high as 20,000 rupees a month. Now, in a year's time, the patient is spending almost 2.5 lakh rupees only on diabetes management. Now, diabetes management doesn't come just because of the cost of diabetes. If the person unfortunately develops a heart attack, because majority of the heart attack happens in diabetes patients, or if they develop end-stage renal disease and require dialysis or a transplant, or if the person develops a brain stroke, or if they lose vision in their eye, or if they develop peripheral neuropathy and they have an amputation of one of the lower limbs, the cost of treatment of any of these complications of diabetes is so high that the cost of surgery is not even visible. So within let's say in 1.5 years time to 2 years, the cost of surgery is recovered by the patient just by avoiding taking those medicines which are now so expensive. And that is just the bottom line. The quality of life, the work performances, that is so much more. And considering this, the central government in 2013 said that uh, bariatric surgery, all their employees and their dependents are eligible, and the government pays for that, and all under CGHS. And from 2020, all the insurance companies are paying for bariatric surgery for their insured persons. So anybody who has a Mediclaim for more than 3 years can claim cashless, can go for a cashless treatment. Now you must realize, insurance never pays anybody without a reason. They don't pay you if you want to lose weight through diet. They don't pay you to go to a dietitian. They don't pay you to go to a gym. They don't pay you to take medicines for weight loss. But they pay a person for bariatric surgery for a reason, because they have calculated that if the person undergoes bariatric surgery, the cost is much less than what they have to pay over decades for your health. So I think without doubt, bariatric surgery works out much more economical, provides better health care and better quality of life. And that is the reason why bariatric surgery is a preferred treatment for diabetes and for weight loss in people where it is required.
Thank you for that answer. Thank you so much, Dr. Goel, for your time and effort you took to share your thoughts and experience with the Docplexus community on this occasion of World Diabetes Day. A big thanks to our dear audience for their kind listening, hoping this session would give you new insights in the treatment of diabetes. Stay tuned for our upcoming session, our ACME, on diabetes A to Z prevention, management, and digital advances tomorrow, 2 p.m. onwards. Until then, stay safe, stay updated, take care, and happy docplexing. Thank you.